Let me welcome everyone here to the April 2013 Barbara Lee and Elihu Harris Lecture Series, The State of Health in America. And we want to be thankful of our honored guests, Dr. Helene Gayle. Welcome to Oakland. And to each and every one of you, we thank you for coming out and spending your time with us this evening. We're honored by your presence. We're pleased and proud of Merritt College and the Martin Luther King Jr. Freedom Center for their excellent work in pulling this program together. And please join me in thanking Parks Chapel AME Church for hosting it. We also want to thank our major sponsor of the Elihu Harris Lecture Series, Congresswoman Barbara Lee Kaiser. And the many other sponsors listed on the back of your program, including Onyx Pharmaceuticals, the California Endowment, Pandora, East Bay Regional Park, for their sponsorship of this series. Each of them has been committed to integrity, action, and service in the community, so we want to honor them for doing that and keeping this series alive. Now, this is going to be a delightful evening. This is one of the things that we've been dealing with for a long time in terms of health. Looking at this lecture series, it's definitely one of the things that is designed to bring forth some new ideas and engage in some dialogue and to hear some things in terms of fostering new leadership for some of the tough issues that we have to tackle in our society today. I also want to bring up a few others to speak as well. I want to introduce the president of Merritt College, Dr. Norma Abris-Galavis. Please come up.
Good evening. As president of Merritt College and on behalf of Dr. Jose Ortiz and our Board of Trustees of Peralta Community College District, we are honored and also in welcoming you this evening for this special event. You know, Merritt College has been known from its early beginnings of being in the forefront of social justice issues about equality, poverty, and education. Today, one of the largest departments at Merritt College is in our area of allied health. So we can identify with our speaker today, and we believe that she holds a wealth of information, but also advocacy. You know, one of the strongest areas to make social change is to be in pursuit of that advocacy and also be very persistent. Through the dedication and the strong advocacy of our Congresswoman Barbara Lee and her staff, they recognize the needs of the East Bay residents. We are fortunate to have this evening our distinguished guest, and we look forward to hearing additional information that's going to help not only us, but leaders of the East Bay to move the agenda of health care forward for the East Bay. Thank you and welcome again.
Also, please join me in welcoming Miriam Salem, a student leader at the Martin Luther King Jr. Freedom Center.
Good evening. We welcome you and thank you for your presence tonight. The Martin Luther King Jr. Freedom Center is honored to produce the Barbara Lee and Elihu Harris Lecture Series. We thank you, Elihu Harris and Congresswoman Lee, for speaking for us. Your courage teaches us that a person is not measured by how they act at times of comfort, but what they do at times of challenge and controversy. Thank you, Merritt College and President Norma Abris-Galavis, for our partnership on campus and off. Nonviolence is just as powerful as any weapon. Unlike other weapons, the weapon we possess is greater than any nuclear force. Our weapon can cut without wounding and create community instead of destruction. Thank you to our major sponsor, Kaiser Permanente. We thank you, Dr. Copeland, for your leadership at Kaiser Permanente. Also, we thank all other sponsors, contributors, and partners. Dr. Gayle, thank you for your participation as part of the lecture with us tonight. Your humanitarian efforts worldwide will never be forgotten by Oakland, America, and the girls and women whose hearts you have touched and led to be leaders in their community. You have taught us that our loyalties must transcend our race, tribe, and our nation. We must think in a global perspective. Not one person can live alone. No nation can survive on our own. We can create peace in this world. Please join the Freedom Center in thanking our dedicated members from the Board of Directors, our Executive Director, Roy, and our wonderful staff. We have more than 100 students and young people from schools and organizations all over the East Bay that have chosen to make meaning of their lives by engaging in public service. Please give these students a hand. Thank you.
Now, she said it was her second time speaking in front of an audience. I think she did a great job. Now I'd like to introduce Dr. Ronald Copeland from Kaiser.
Good evening. Well, isn't it wonderful to have these young folks present like that and provide that kind of inspiration? Well, I'm pleased to represent Kaiser Permanente tonight and to thank Dr. Davis, our distinguished guest for this evening, and all of you for attending for this very important lecture series. For Kaiser Permanente, a critical part of our mission in the pursuit of health for the people we're privileged to take care of, as well as the communities that we serve, is to be a partner in the fight for inequities regarding access to quality health care and the elimination of disparities. Fundamental to that is increasing education, encouraging dialogue to develop new ideas, new approaches for making a difference and having impact. So a lecture series of the nature we're going to experience tonight is a critical part of that, and that is one of the reasons that we're very thrilled to be involved in this activity. But as important as access to good health care is, we know that access is not enough. It's necessary, but not sufficient to improve health. There are many drivers of health. Your family history, your genetics represents about 30%. Your environment and your social status is about 20%. Medical care is only about 10%. 40% of the impact on your health, the drivers of your health, are the personal decisions you make every day regarding your lifestyle and behavior. So while health care for many is not optimized and still many battles need to be fought, your ability to decide whether you will smoke or not, your ability to decide whether you will exercise or not, to be careful about your diet, to enjoy your health and to pursue your health on a regular basis, that's critical. And for all the young folks in the audience, you're never going to have a better time to form good health habits than now. So my encouragement to you is to start early. But all of that being said, there is no more devastating barrier to achievement of health than the impact of poverty. Poverty does a lot of negative things, if you will, as it relates to health. It decreases life expectancy, it decreases health, but more importantly, it demoralizes and it causes people to lose hope and their motivation to continue to stay in the fight to be healthy. By that definition, some would consider poverty a weapon of mass destruction. Sometimes the zip code is a better predictor of your health status than your actual measurements or your vital statistics. And that's related to the impact of poverty across this country. But I want to encourage us, as our student did, to rise above the circumstances, to take control of those things we can control while we try to fix the rest of the situation. So I hope you are tonight all eyes and ears. We have tremendous guests who are proven champions of human rights, will possess brilliant minds and will share great ideas with us and have great compassion for the importance of this work. So I believe at the end of the evening, we will all be informed, inspired, and compelled to further action. So on behalf of Kaiser Permanente, we wish that you be well, that you live long, and that you thrive. Thank you.
Now today, people are finding it harder to get out of poverty, especially after this last recession. And what's interesting about this last recession is that the wealthier got wealthy, or wealthy got wealthier. And when you look at the data, as Dr. Copeland mentioned, in terms of looking at your zip code, it could tell you what your life expectancy is. We've done this for Alameda County. We've mapped this out. We've also looked at it from the standpoint of health data, so matching poverty with life expectancy and health factors. And they overlap. Okay. They overlap for a number of different reasons. Dr. Copeland also mentioned your personal choices, your habits. And those habits are often dictated by the choices that are around you. So you could be choosing from bad and worse, okay, depending on where you live. So those things are extraordinarily important for us in terms of looking at health. As a result of that, in the years since 1960, we saw a difference in life expectancy between white and blacks of 4 years. Come to 2010, that grew to about 8 years. Yet things are getting better in terms of health care. With the passage of President Obama's Patient Protection and Affordable Care Act in 2010, and it being upheld by the Supreme Court in 2012, we are witnessing the early stages of implementation of one of the most sweeping and comprehensive health reform laws since Medicare in 1965. There are 3 overarching strategies in the Act, and at the heart of it, it's about increasing access to health care, and also improving preventive and chronic disease care, as well as improving the environment in which people live in order that they make healthier choices. Most of the provisions of the Act begin in 2014, with full implementation by 2018. So there's a lot coming forth in terms of that Act. And if there was any time in which you need to understand the state of health in America, it is now. So tonight it's an honor and privilege to be in the presence of 2 extraordinary women who have consistently led and supported efforts to improve health both here in the United States and in the world. Congresswoman Barbara Lee has been a forceful and progressive voice in Congress. She doesn't hold back. We know that. We appreciate that, and we applaud that. First elected to Congress in 1998, she's been there pushing the belt in terms of what needs to be done, fighting for social justice, trying to get equitable arrangements for people, including in energy for folks with low income, supporting them so that they can live in their homes and having energy. Every piece of legislation that's come out related to HIV, she's been a part of, and we appreciate that. We're in a state of emergency here in Alameda County related to HIV. She's been aggressively representing the needs of the underserved and vulnerable people in her district and throughout the United States, vigorously advocating for a wide range of social and economic concerns and bread and butter issues, the things that affect you most. So we want to appreciate that, and we want to thank Congresswoman Barbara Lee and invite her to the stage. Now, our honored guest tonight, Dr. Helene Gayle, is the President and CEO of CARE USA, a leading international humanitarian organization whose poverty-fighting programs have reached 122 million people last year in 84 countries. That's a tremendous amount of work in terms of the organization. Under her leadership, CARE has strengthened its focus on long-term impact, increased policy and advocacy efforts, and deepened its connections between poverty and the environment. Her poverty-fighting programs, Dr. Gayle has led efforts to reinforce CARE's commitment to girls and women to bring lasting change to poor communities. She's an expert in health, global development, and humanitarian issues, and spent 20 years at the CDC, the Center for Disease Control, focusing on combating HIV, STD, and TB programs, as well as directing the HIV, TB, and reproductive health program at the Bill and Melinda Gates Foundation. She was named one of Forbes' 100 most powerful women, Foreign Policy Magazine's top 100 global thinkers, and Newsweek's top 10 women in leadership. She was born in Buffalo and earned her BA in psychology at Barnard College, her medical degree at the University of Pennsylvania, and her Master of Public Health degree from Johns Hopkins University. She's board certified in pediatrics, which means she loves people. Please join me in welcoming Dr. Helene Gayle to the stage.
Well, first, let me thank you, Dr. Davis, for that very warm introduction, but also for the phenomenal job you're doing each and every day here in Alameda County. And also to Dr. Copeland, to Roy and Karen, to our unbelievable students at the Martin Luther King Freedom Center. Give them another round of applause. Marina, you were wonderful. You were great. Thank you. Every year, these students, 5 or 6 of them, go with me to Montgomery, Selma, and Birmingham. We march across the Edmund Pettus Bridge with Congressman John Lewis. This is a real life transformational moment for our young people. And they come back here, and believe you me, they redouble their efforts in terms of their work in this community. And I am very, very proud of them. The center's been in existence since the mid-90s, and it's withstood the test of time. We're doing something right. These young people are examples of the possibilities. And so I just have to thank the board, Hillary, and everyone for your support and for making sure that they have the future, because they are our future leaders. So thank you so much. You can give our young people another round of applause.
Yeah, and I just want to add, too, I had the opportunity, I was with them this afternoon. They interviewed me for, I think, 30, 40 minutes, and some of the toughest questions I've had to answer, but they were really great, and so it was a real inspiration for me. It's an incredible treat to see young people who are thinking so profoundly and deeply about the world they want to create. So.
And there's such a reflection of this great community. This district, first let me just say, in Elihu's absence, let's give Elihu Harris a round of applause, because he worked so hard on these lecture series. He couldn't be with us tonight, but he's here. But this congressional district is a phenomenal congressional district, and I have to take a moment to just say thank all of you for your support and for your love over the years. Tomorrow, I will have been in Congress for 15 years. You elected me, and I was sworn in on April 21st, 1998. Gosh, how the time flies. And you've had my back, and I just have to thank you so much for that. And also, I was explaining to Dr. Gayle a little bit about my district earlier, and letting her know that here in the 13th Congressional District, we care about health care in a broad sense. We care about our individual health care, our family's health care, the health care of our community, but also the health of the world. This district is a district, yeah, you know, we're a global family, right? So this district has always thought locally and acted globally. And I'm very proud of that, because some members of Congress want to know or won't take on the big issues of foreign policy and international relations because their constituency will not allow them to do that, because they think they should only be focused on their own districts, which of course is first priority for all of us. But I think my district really has been the leader in progressive politics and be an international leader. So I just have to thank you all for that. Now, you heard Dr. Davis tell you a little bit about our guest tonight, Dr. Gayle, in terms of her background. But oftentimes, you know, you see this brilliant woman, and I've been with her in Uganda, leading this major international organization, CARE, and you wonder how this physician who was with the Centers for Disease Control for 20 years, chaired the President's Advisory Council on HIV and AIDS, how she made that leap from being a doctor, a pediatric doctor, into being one of the most powerful women in the world. So, Dr. Gayle, could you tell us what that transition, how that transition was made?
Yeah, well, I'm not sure if I've quite made that transition.
Well, Forbes magazine says
yeah,
so that's okay, right?
Yeah, but, you know, and first I would love to just say thanks to you for really being an inspiration for this and also an inspiration for me. Somewhere in the introduction, somebody mistakenly said Dr. Lee and then said no, Congresswoman, but you know, I think in many ways the work that you do has helped to make a difference in health much greater than what any one doctor could do. So, you know, you are Dr. Lee. but so to your question, and it's a question I get asked a lot, you know, you started out as a pediatrician, now you're heading an organization focused on global poverty. You know, how did that all come about? And, you know, when I think back on why I went into medicine to begin with, it was because I wanted to have some way that I could tangibly make a difference and have an impact on people's lives. Loved pediatrics, you know, dealing with children, sickness or in health, it's wonderful. And being able to see a child develop and grow is, you know, just an incredible experience. But as I was doing my training in pediatrics and taking care of individual children, you know, I started thinking about the children who didn't come in and the children who didn't have access to health care and health services. And I saw in my clinic oftentimes children who were coming in unnecessarily because they may come into the emergency room for something because they didn't have continuity of care to begin with. And so I started thinking about how you can take the tools of medicine and think beyond the individual to thinking about how can you have an impact on populations. And so that led me into public health, which is, you know, if clinical medicine is the care of individuals, public health is the care of populations. And really thinking about how could I have an impact on broader populations. So it led me to get my master's in public health and then go on to Centers for Disease Control, where I thought I would stay for 2 years, get some training, and then go back into clinical medicine. Obviously, I got there and stayed for 20 years. And when I was starting out at the CDC, it was in the early to mid 80s, right around the time when the AIDS epidemic was unfolding. Initially, I went and when I was asking people about what should I do and where should I focus my time, many people said, do anything but stay away from that HIV because, it's not really serious. It's just this political disease, and we'll find a cure and it will be done. So I didn't heed that information and ended up focusing on HIV and AIDS, which clearly became the leading public health issue of our time in this country as well as globally. But as I worked on HIV, both in this country and around the world, I started realizing that, in fact, the reason that people disproportionately get HIV has less to do with the virus and more to do with underlying social issues. Whether or not somebody has access to health information, health services, whether they're poor, whether they're a woman in a society where they're discriminated and don't have the ability to negotiate safer sex or have to sell their body in order to feed their children. And so as I worked on HIV, I realized that if I was going to have an impact on HIV, as well as other health issues, that in the end, it's about how do we have an impact on poverty and social inequality overall. And so that's kind of how I went from being a pediatrician and looking at one child and thinking about how can you have an impact on this absolutely inexcusable inequality in people's status that happens to be linked to the random accident of birth. And so how can we make this world more prosperous, more stable, more equal for everybody around the world, and that's why I do what I do at CARE.
Well, let me just say, first of all, Dr. Gayle, the Bill and Melinda Gates Foundation, between the time that after you left CDC and before you became president of CEO and CEO of CARE, she was with the Bill and Melinda Gates Foundation, heading up an HIV, their entire operation on HIV and AIDS. And we became friends, and I started talking to Dr. Gayle about all of the issues that she was dealing with globally now. And they were the same issues that we were dealing right here in Alameda County. For example, HIV and AIDS. When you look at the disproportionate rates of HIV and AIDS as it relates to communities of color, especially the African American community, when you look at now in the South especially, the highest rates of new infections are among Black women in the southern part of the United States. But then we look at sub-Saharan Africa, and where are the highest rates of HIV and AIDS? In the Caribbean and Haiti and in sub-Saharan Africa. And then I began to look at how we would address this, not only our domestic response, but we had to have a global response. Because what we know about HIV and AIDS here and in sub-Saharan Africa, they're very similar. The causes, the behaviors, the medicines, the lack of access to medicines, the poverty, the social determinants, you know, all of those issues were very similar. And so what I learned also with Dr. Gayle in Uganda, I was in Gulu in northern Uganda, and we met with many, many people who were war weary. They had been in a war for many, many years. And many of the symptoms, the stress, the alcoholism, the violence against women, the family dislocation, all of what I saw in Gulu, I'm seeing here in Alameda County. But yet I saw CARE and what Dr. Gayle put forth in terms of their programs, and I said, you know, we could learn a lot about best practices that some of CARE's international programs are structured around, and maybe really begin to look at how we think out of the box here, because you know we had to declare here in Alameda County a state of emergency as it relates to HIV and AIDS in 1998. And so we've got to really look at new ways to address care, prevention, treatment, because we will fight and we will see an AIDS-free generation in our lifetime. So can you tell us a little bit about some of those programs and best practices that you think could be applied here in our own country that you have seen as successful abroad?
Yeah, you know, and I think as I've bounced back and forth in my career between domestic health and international health, you know, I think there's so many things that we probably do better internationally, sometimes because of a lack of services and a lack of access that really forces people to think differently about the way program, including health, is done. You know, one, I think, is that we go to the communities, and we really do work with communities in a way that doesn't impose what the answer is, but really works with communities to make sure that they are very much, that they own the programs, that they feel that that the programs are tailored for them. You know, I think the fact that in countries that we work in where there's lack of access to people who would be considered medically trained nurses, physicians, means that, you know, the use of rural health workers who actually can take care of many more things that makes the system much less expensive than ours, which is so physician dependent oftentimes for things that we don't necessarily need to have physician care. And so I think the extension of different kinds of workers and really thinking about what are really the needs and how do you pull a system together in a way that really looks at who really is able to take care of whether it's health information or basic services in a different sort of way. And I think the focus on prevention, again, partly because of lack of access. We saw that in HIV where unfortunately the lack of access to medications early on in the epidemic meant that much greater stress was put on prevention. And we now see, and we were talking about it earlier today, that we have so medicalized HIV that we're not thinking about how do you prevent to begin with. It is wonderful, and we know we're still lacking in terms of access to AIDS medications here. We're worried about what's going to happen with Ryan White, et cetera. But you know, I think we have shifted the focus so that that preventing HIV, or any of the other diseases, whether it's obesity, and all that comes, all the behaviors that go into chronic diseases. So I think this focus, and Dr. Copeland talked about it earlier, this focus on really thinking much more upstream. How can we do more to focus on prevention and look at what are we doing both for individuals, because it's how individuals change their behaviors, but what are the supporting behaviors in communities? How do you have communities take on health as a key issue for the communities so that we're shifting norms and we're making healthy behaviors become the norm in our communities here or around the world. So I think those are the kinds of things. It's really, you know, mobilizing communities in a way that takes on health as a key issue, shifting the way behaviors what behaviors are supported, and then looking at how do we develop a system that really best meets the needs of communities and engages them in the process.
And as I listen to you, now this is what you're doing abroad in sub-Saharan Africa and India, all around the world, but it sounds like we could kind of figure that out here, that part of what we need to do really is help our communities become empowered.
Yeah, and I think another part of that is that, you know, we do our programming in a very integrated way. And so as you saw when we were in Uganda, we have our microfinance and village savings and loans programs where people are able to use economic empowerment to integrate that with health services. And so just like in our communities here, we know that a lot of the reasons that people engage in unhealthy behaviors or don't access health services is because they lack the economic means. And so we've got to think about economic empowerment, housing, all of those things in an integrated way if we're going to have the kind of health outcomes that we want. So it's that integrated approach that, again, I think we could take from examples and experiences overseas.
Sure. Well, you know, with the Affordable Care Act now, many of the provisions of the Affordable Care Act that address health disparities in communities of color especially, we worked on as the Quad Caucus. It was the Black Caucus, Hispanic Caucus, Asian Pacific American Caucus, and Progressive Caucus. We helped write that bill and put in provisions that would do many of the initiatives, provide many of the initiatives that you just laid out. For example, of course we know that there's a shortage of healthcare physicians and healthcare workers in this country. So we put into and I hope you all really get involved in this as we implement the Affordable Care Act, because we put provisions in there for training for healthcare workers at the community level. We put provisions in the Affordable Care Act for workforce training, because this bill, or this law now, is going to be a huge job creator. And we have to really get prepared for and I hate to even think of healthcare as being an industry, because it is a right, a basic human right. And I support single payer and the public option, but while we have the affordable, this community supports that. Thank you. And we'll get there. But we're halfway there now. But with the Affordable Care Act, it will create a whole industry of new jobs. And so we have to be prepared to really be ready for those new jobs that are going to be created out of this industry, so that we can begin to empower our own communities for the health of the community.
Exactly, right. And so, you know, full employment is a health intervention.
That's exactly it. Let me ask you about the whole issue of integrating, and we saw this again in Uganda, as it relates to women empowerment, healthcare of women, violence against women, and how care really works that out with the men in a woman's life, her partner, her husband, her significant other, and the children. Because I saw some really exciting models that CARE uses in terms of how to reduce violence against women with men participating in that whole effort.
Yeah, no, exactly. And it's one of the areas, as was said in the introduction, one of the areas that we have really focused on in our work is empowering girls and women. Girls and women make up most of the poor people around the world. Disproportionately, poverty impacts girls and women. But if you can change the life of girls and women, you also change the life for the children and communities. And so if you can educate a girl, you start that girl's life on a totally different trajectory. She won't get forced into marriage at age 12 and 13. She'll have fewer children. Her children will more likely go to school, et cetera. And so you really do, this focus on empowering girls and women, we see as a way of really helping whole communities move forward. But in doing that, it means that we've got to also engage men and boys, because if we only work on one half of the equation and not the other, you're not really creating change. So we put a lot of focus on, in our work, as we look at empowering girls and women, how do you also bring men and boys along and engage them? And some of the work, and this is the kind of project that you saw when you were there, we have a major focus on women saving and pooling their resources so that they can take loans, collectively pooling their resources, and then using those to give small loans that they then can use to start businesses and then continue to repay and then make larger loans. And it's a way that, with just small amounts of money, we have seen women develop economic power in a way that also helps to develop their self-confidence, their stature within their families, within their marriage. And I think one of the programs that you saw, one of the men kind of gave testimony who said, I used to beat my wife, I used to drink, I was a bad father, I was a bad husband, but now that my wife is a contributing factor in the family, we've worked together, and there's education for the man and for the woman. And he said, well, we've worked together. I now have a different opinion of my wife. I see her as something of value, and we've become real partners. The violence has stopped. I wouldn't do that again. And now I talk to other men about how to treat their wives with respect. And all of this starts with this kind of looking at how do you give a woman a sense of value, give her a sense of self-esteem, and how that changes the dynamics within the family. The men change in the process, the whole family changes. And so, that's the kind of change, ripple effect of change that can have such long-lasting impact.
And so often, I think our services here and our approach is so segmented and bifurcated.
Right.
And I remember this young man. He actually had stopped drinking. I remember He told us all he did in his prior life before care was drink from sunup to sundown, and he had not had a drink since he was part of this whole transformational process. But we in this country, and we're trying to coordinate now services. Violence Against Women Act, it was just passed, signed into law. It was very difficult. Get that done, very hard for the political reasons that you all know, but we did it. But I think as part of a strategy that I think we need to use as it relates to domestic violence, because we know that many of the injuries that we see in emergency rooms are as a result of domestic violence. We need to figure out a more comprehensive approach to domestic violence issues, how we prevent this from happening from Jump Street, and how we engaged the family, the male, the children, whomever, the community in all of these issues around domestic violence, because it is a health care issue.
No, it is, and I think one of the things is, we have to have an honest and open dialogue about it. And in many of the programs that I've seen that we've worked with around the world around gender-based violence, it really starts with a conversation. And it starts with a conversation with the men, really talking about, well, why do you, participate? Why are you, beating your wife? Why do you commit violent acts in the home? And a lot of it is because that's how they grew up. That's what they saw. That was the cultural norm. And when you start saying, okay, what was the impact of violence in the home? And it's not a positive impact. They start recognizing that there are alternatives, that there are different ways of resolving conflict. And then men become advocates themselves for changing. So it starts with a conversation, it starts with a dialogue, it starts with opening up the awareness, and starting to peel back some of the reasons why people commit violence in the home, and what's the basis for that. And you know, I've seen it change, and sometimes it's just by starting that type of conversation and giving somebody the support and the options to resolve conflicts differently.
Yeah. And once again, you know, part of what we're trying to do is show how what we've learned abroad, you know, can really be applied in some ways, of course, with some changes and modifications here at home, because we're struggling to find new ways of doing, you know, healthcare here in our own country. But also, I think, and what I've seen abroad is, especially in Africa, the models that we use here, you know, are very enlightening to the people in sub-Saharan Africa, and they want to know what we're doing here in Alameda County. How are we dealing with injection drug users, for example? You know, how are we addressing prostitution and sex workers? You know, what are we doing in terms of men having sex with men and transgender communities? And how are we addressing poverty, you know, and hunger in our own country? And so people abroad really want to know what we're doing.
Right.
And so we have a real duty and responsibility here, right here in the Alameda County, to step up, which my county is stepping up more than any other county, I think, in the whole country with minimal resources. But just know that people around the world are looking to us to see what we're doing so that they can also learn to do the right thing.
Right. No, and I just think there's so much that we can gain by having that kind of bi-directional dialogue. And you know, I have seen, as you said, you know, people just hungry for the kinds of information and examples that we can take from some of the things that we do right, and also people can learn from some of the things that we do wrong. So I think having that opportunity to have that exchange is so important.
You know, and I just have to segue right now into our budget, the federal budget. How many, and I've just got to ask this question about foreign aid. How many of you think that foreign aid is maybe, 25% of our federal budget? 15%? 10%? 5%? Less than 1%? See how smart my constituents are? It's less than 1%.
You've got much better informed constituents than most people, because most people, the average, people think that we spend something like 25% of our budget on foreign assistance. And so, you know, if you ask people, do you think we, you know, what do you think we spend? They'll say 25%. And if you ask people, do we spend too much? About 50% of the American population say we spend too much on foreign assistance. Well, that's because they think we spend 25% of our budget. Well, I think 25% is too much too. I mean, you know, we do have, you know, a lot of need here in the United States, but we spend less than 1%. You know, that's a lot in terms of dollar amount, but when you think about our proportion, we're lower than most of the other industrialized nations in terms of the proportion of our budget that gets spent on foreign assistance. And if you know, all the polls say, if you ask people, particularly in this issue of health, if you ask people, do we spend enough to make people healthy around the world, people will say, no, we don't. And so we know that people are willing, that the American population is willing to spend more, you know, more than what we do spend, and we only spend, you know, less than 1%. And it's the target that people always go after when we're having budget crises. So, you know, you have some of your colleagues who, the moment there's a budget crisis, the moment there's a tight budget, it's always cut the foreign assistance budget, less than 1%. And I think it's some of the best spent money, and it's not because I do the work in that, but if you look at what we get out of that in terms of building communities that one day will be our trading partners. You know, you look at a country like South Korea that was a recipient country, that was a country that demanded aid. Now that's one of the strongest economies around the world, you know, and you can go example after example. So, you know, it's in our best interest to make other countries prosperous, because in the end, we all win. It also is important for stability. You know, we know that countries that are poor and ignorant, have lack of education, are the ones that are more prone to instability, conflict, terrorism, et cetera. So, you know, I think that 1% is a huge, the huge return on investment for a little bit of resources. And the American people would like to see us do more.
That's right, because international development and foreign assistance is really a national security issue. It's smart security.
Right.
And the argument that many of us make is, look, if you don't really care about poverty, global poverty, famine, development, think about the United States national security interests.
Right.
You know, terrorism in many ways is breeded in despair.
Yeah, feeds on-
And, you know, who's going to go in and help develop the country? Who's going to provide education and health care for minimal resources? Well, if the United States does, you know, then, you know, a lot of, you know, of the conflicts could be reduced. And I'm on the subcommittee on foreign operations of the Appropriations Committee. And this is the fight we're in right now. I mean, you should see this budget that
Right.
the Ryan budget wants to decimate every program that Dr. Gayle is talking about, but also the Ryan budget wants to decimate every program that we're talking about here at home. They want to decimate the Affordable Care Act. They want to get rid of almost the Ryan White Care Act. I mean, you know, we've got to make that whole until we transition everyone into the Affordable Care Act. They'd like to just totally dismantle everything. Mm-hmm. And so, you know, it's on, the assaults are now on both fronts, on our domestic programs and the safety net and healthcare, but also on our international development programs. And so this is one struggle. If you don't believe it based on what we're talking about earlier, based on what we talked about earlier, believe it when it comes to the budget fights, because they want to get rid of both budgets.
Right, you know, and it makes me think about the importance of citizen advocacy. And, you know, it's something that we take very seriously and put a lot of focus on developing people who can speak up for these issues. And so at CARE, we have a network of 100,000 plus volunteers around the country, our CARE Action Network, people who we can mobilize to write letters to Congress and talk about these issues, because there's not a big constituency for global poverty. There's not a big constituency for these issues. And if people don't speak up, they don't give you the cover that you need to be able to vote for these issues. And whether it's on global poverty or health or whatever the issue, I think the importance of people using their voice and making sure that people, policymakers, know that these issues do matter to us as a people, you know, is so important.
And this community is very active. I mean, I get more emails and letters, I think, than most members of Congress. But I would urge you and encourage you, for your friends and family members who live outside of my district, let them know how important it is to do what Dr. Gayle said, because whether it's on the Affordable Care Act and Social Security and Medicare and Medicaid and all of the efforts that we care about so dearly here, or whether it's about our international development programs, the opposition is the same. Yeah. And so we need to really let the word, you know, send the word out throughout the country that they've got to not only be strong advocates for our domestic priorities, but also for our development priorities. Because I want to see this foreign assistance budget go up. I mean, I want to see it at least 10 to 15% of GDP. I mean, it doesn't make any sense less than 1%. I mean, you should see what these organizations with minimal resources are doing around the world, and it's really incredible. And we need more money.
Yeah. No, and we need the support for this as well as other issues.
You know, finally, let me just say a couple of things about the PEPFAR, this is the President's Emergency Initiative for HIV and AIDS. We actually wrote that bill, and it's a piece of legislation that's now law that has really saved the lives of millions and millions and millions of people throughout the world. This actually began under the Bush administration, and I initiated it with the Congressional Black Caucus. We got President Bush on board, he signed it into law, and it was, even though there's some problems with it still, but it's a good thing. It's saving many millions of lives. But what we didn't have was our own domestic PEPFAR.
Right.
And so we went to candidate Obama and said, look, you know, we're doing all of this work abroad on HIV and AIDS and tuberculosis and malaria, because the opportunistic diseases are all part of the whole response that we have to address. And we talked to then candidate Obama and said we want to have our own domestic PEPFAR. And to his credit, on World AIDS Day, right after he was elected, he announced the fact that he was going to come forward with and we worked with him on this, a national AIDS strategy and a national AIDS plan.
Right.
And I'm very pleased that that's moving forward. And even in the budget, you know, that has not, his budget did not cut that. And we're trying to put more resources into our domestic PEPFAR. But again, we try to just integrate the international with the domestic so that the Congress could see that they couldn't pit us against each other. Yeah. That we had to have both budgets.
Right. No.
And both plans.
And it's you know, another one of these examples where I think internationally we did a better job of what PEPFAR did and the AIDS programs internationally that really developed comprehensive programs. So you can go comprehensive plans. I mean, you can go to any country in the developing world and see their AIDS plan. We didn't have an AIDS plan in this country. And, you know, I was very pleased to chair the President's AIDS Commission when that national strategy was being developed and being able to be a part of rolling out for the first time since this epidemic an actual national plan. So we now have one, and it's focused, you know, on equitable access to health services, eliminating the disparity, reducing stigma and discrimination. You know, the key things that we need to do to move the needle on this epidemic here in the United States. But, you know, to be this many years into the epidemic, to first, as the United States, have its first national plan, you know, better late than never, but, you know, we took a long time doing what has been done around the world for decades.
And that was one of the reasons that we worked so hard to get the travel ban lifted, right. Because this was a terrible travel ban against people with the virus were not able to come into the United States. And as a result, we could not have an international AIDS conference in the United States. We had not had one for 22 years. So we worked really hard, again, with then President Bush, and it was my legislation that we fought hard to get passed, but he signed it. We got it into the PEPFAR reauthorization, so they had to sign it. Or take the whole bill down. They didn't want to do that. But then President Obama issued the regulations, and we were able then to move forward and have the first international AIDS conference here in Washington, D.C., in our own country, after 22 years. Right. We had that last July.
Right. No, and I still remember, I guess it was Toronto.
Toronto, you were in Toronto.
Standing on the steps, we were both taking part in a march, and you were talking about, you know, here we are in Toronto, we're in Canada. Why don't we bring this conference back to the United States? And the last one had been in San Francisco 22 plus years ago. And you said, well, you know, why don't we just bring this back? I said, well, because, you know, we have the travel ban. You knew about of course, knew about the travel ban. And you said, well, I'm going to change that. And, you know, in typical Congresswoman Lee form, everybody said, no, it can't be done. We've all been trying to do this forever, but you persevered and got that travel ban done. So we didn't stand. So that we're no longer up there in the category with about 5 other countries like Iran and a few others that didn't allow HIV-infected people to travel freely into the country. So, you know, it's a great victory, and we were able to bring the conference back home. It was a great conference, but, you know, to be able to do that kind of activity, and again, it's why I go back to how important it is for people to make sure that they're not just emailing you, but also thinking about how to make sure that our voices are heard more broadly, because, you know, with having more support to push some of these things forward, you know, that's how we're going to get the kind of change that we need. It's having the programs, but it's also having the policies that support them.
And we're going to do that. And you know, this district, again, is a very action-oriented district. It's a district where, I mean, I look out and I see so many young people who are already activists because we have so many great leaders who have come from this district and still have that level of activism. And it's, you know, and every issue is political. The Affordable Care Act, you know, to see this rollout take place in the proper way, to make sure the Medicaid expansion is conducted the way it should, that we get the resources here, to make sure that the healthcare workforce is developed the way it should be in terms of the curriculum and what have you, to make sure that our community colleges and Peralta and all of our wonderful institutions here benefit from what the research and all of the provisions of the bill. We're going to have to really raise some cane, you know, put some more street heat out there on, you know, elected officials, because we could lose it all if we don't know and recognize that this is political. A lot of people don't think that, not in my district, but a lot of folks around the country, I swear not in my district, but they don't see these struggles. They don't see healthcare as being political.
Right.
They don't see housing as being political. They don't see the environment as being a political issue. But we know that everything is political, and so that's why engagement and activism is so critical to what we're talking about. Thank you so much for being here, for gracing us with your presence, and for really educating us all tonight. Thank you so much.
Thank you. Thank you.